Yeah. So when I initially pitched the idea of this presentation, it was really like, where do we go next with the shared care records? And John sort of paraphrased that, as John does, and said, okay, we're at base camp 1. We've done MVS 1, we're all there. Where do we go next? So that's how we ended up with this theme. So I'll just give it a little short journey before I hand over to the other presenters about how we got to base camp. So we started, as James alluded to, many years ago, 2015. There was a homicide in our region, and the coroner's report said basically if you lot, because that's how they referred to us, had shared your information, this could have been avoided. And we had an individual who'd travelled between multiple mental health trusts, and if any one of those mental health trusts had realised that he'd visited another mental health trust a day before or 2 days before, the whole treatment plan would have been different, and this could have been avoided. So we came up with this idea of why not we don't just share the information. And at the time, there were 4 mental health trusts in our region involved in the coroner's report. We got together and we said, look, let's just do this. Let's just make this happen. There was a big sort of conference between the CEOs and everybody else involved. And they looked at us, the techies, and said, look, can you do this? And we're like, yeah, of course we can. It's just tech. So that's how it started. And that's how our sort of regional shared care record started. It started 2015, 2016. Now, at the same time, as James alluded to, the MIG was in our region, and we were looking at sharing primary care data back to the acutes in the first instance. This developed, and that's what it looked like at the time. You know, it was pretty simple, pretty basic. So straight away we said, look, let's combine the two. We should only have one portal, because that's how we used to refer to it. And we got West Midlands Ambulance Service involved very early on because they literally travelled between all our sites. So we had, unbeknown to us, because shared care records were just being talked about. We were just coming into sort of the language that we were starting to use in the NHS. And we created the shared care, our first sort of foray into shared care records. But when we started, one of the things we wanted to get straight at the time, I mean, the IG was obviously one, and I'm sure we've all got IG discussions and stories about that. But it gave us, the IG sort of debate gave us time to think about where do we want to go long term. And from the outset, we realised we had to get the groundwork right because we wanted this to last and be something bigger than what we'd started at. So standards. So we alluded to them earlier in the presentations. Standards were key for us. So we were looking for some organisation that could provision all current standards, but also had a foot in the future standards, interoperability, interopen, that sort of thing. And we also worked out very quickly that things like RBAC, audit reports, etc., were highly important. They were important not just for the use of the shared care record, but they were important when we were selling the idea of a shared care record. Because when we initially started and we said, look, we want to share data, that's something that was new. That was, you know, up until then, your data and your controllers of your data, you know, it was all taken very seriously, as it should be. But it was also very insular, and it was inside my wall. And we were trying to break down those barriers. And we were trying to look at new ways of thinking with clinicians, with IG leads, and others. So we wanted to get sort of the foundations right. And that was our basic architecture when we first started. It was very simple, 4 servers. And we went with, I'll come on to InterSystems in a moment, who are our supplier for our shared care record. They came up with a novel model for us on the sort of the architecture piece where they had a thing called an edge gateway. And at the time it was like, okay, what's an edge gateway? And it's basically each trust keeps their data outside the main shared care record inside their own edge gateway. It's all in the cloud, but they've got control of it and they owned it. So it wasn't just put into the melting pot. That was an easier sell to a lot of our end users, a lot of our organisations. Now, I mentioned the standards earlier, and you saw the bubbles of all the sort of fire, HL7, etc., etc. We had some pretty basic. We had both ends of the spectrum here when we were dealing with our first sort of clients. We had one mental health trust, myself and James work. They were a GDE, and they were able to do almost real-time data processing. They were already looking at fire very early on. And at the other end of the spectrum, if we could get an Excel spreadsheet, we were going to be lucky out of one of the trusts. So we knew that we had all ends of the spectrum to deal with, and we wanted others to come on board as well. Like I said, we had conversations with West Midlands Ambulance Service. We were talking to Health Share Gateway around the MIG. And we the sort of the procurement process that everybody else does. And we came up with InterSystems. And at the time, you know, we went through hell and high water over the procurement. I didn't know. I'm not fanboying, by the way, about InterSystems. They're as bad as every other, or as good as every other provider. I just want to put that out there now. They are first in class, as they're going to tell me anyway later, so I might as well put it on the screen. I didn't know that at the start. But I was asked, when we went out to the procurement, I also had to go back to my chief execs and my CFOs and everybody else. And they said, okay, so this is a pretty big endeavour we're going for. Why have you chosen InterSystems? So I said, you know, we did all the procurement stuff, and they come out, we scored them accordingly. Okay, so they said, right, okay, tell me something that really differentiates them. And I said, well, they've got the shared care record for New York State. And my CFOs weren't particularly impressed. I was, but they weren't. Until I said, that's 266 acute trusts on one shared care record. And they went, how many? I said, 266 acutes. So they said, okay, that's pretty good. Have they done anything else? And I said, yeah, well, they've got Texas. And they said, oh, yeah, how big's that? How many hospitals they got? I went, 571. Okay, that's impressive. And the thing that's swung it for me is they actually do the Veterans, they don't call it the Veterans Association, but in America, the Veterans, and they've got 1,400 community sites across the whole of the States. And that pretty much that did give me confidence, to be honest with you, that they could do what we were asking to do. You know, and I got asked, is it scalable? I said, obviously it is. And they were like, yeah, but we bought exactly the same as what New York State's got, and we had. I'm not fanboying over them, but for me, from the tech perspective, this has always been a step in the right direction. I've never had to worry about it. So I am grateful in that respect. There's other bits they need to work on, and I'm happy to talk about them later. So we'd got all this basic architecture in place, and we were all relatively happy with the supplier. COVID hit. We all know about it. We all know about the issues. But one of the positives out of COVID, and I know there aren't many for people, but one of the came up for me was around the tech and the tech acceleration. So in Birmingham, you may remember, we were going to have a Nightingale hospital. And we had a big meeting in Birmingham, how were we going to cope? West Midlands Ambulance Service, all the acutes, etc. And what came out very quickly was these patients were going to pitch up with nothing. We were going to be lucky if we got a piece of paper saying they've got COVID. And we were asked, is there anything we can do? And I said, well, yeah, we've got a shared care record. It's operational. It's not vaporware. It was real. We had we had the mental health trust on it. We had the GP data in there. We were connected to most of the acutes in our patch. And I said, I think we could do it. And literally, that's what happened. We had a conversation, myself, James, we rang InterSystems, and we said, look, we need your help. It's a national emergency. And you know what? They were on board. And Paul is in the audience. He doesn't work with them anymore. He's changed platform. That doesn't mean you have to, but he has. But he was, he was there. He was part of the conversation. And together, we accelerated the shared care record. And they did it at risk. And I want to say that to give them acknowledgement, because we had no money. We thought there was money in the pot, but we had no money. So I spent £1 million of the NHS's money, by the way. I didn't sleep well for about 6 months. But InterSystems were in it with us, you know what I mean? They were sweating as well. So that was cool. And that's what it looked like, dead early on. That is what it looked like. And it was great. And we had all the tabs, and we started to get things doing, and we connected to most of the acutes. We tried to do I think it's worth mentioning on these presentations that you do the good and the bad, because it's not all good. So we tried to create a West Midlands shared care record. Paul was there as well. It didn't work. And the West Midlands is split into two. For those who don't know, effectively, we've got the south of the West Midlands on the InterSystems platform, ourselves, and we've got the north of the West Midlands on the sort of the GraphNet platform. And we tried, and we wanted to do it using standards. That was the key, and that was the push. We wanted to do it with FHIR. So we wanted to use FHIR transmission principles. And we wanted to get the data in structured data. And you know what? We were nearly there. So we managed to get the GP data flowing between the two organisations. And it just, you know, I'm not here to beat any suppliers up. GraphNet were heavily embedded in their proprietary software, and it was a big ask for them. And they needed a longer. So they stuck with the proprietary software, and they saw the NRL as an opportunity to connect the shared care records. So regrettably, it didn't happen. It's the way it is. So we were left with the 3 ICSs that you see before you today, Covent Warwick, Hereford and Worcestershire, and Vsalt. So I'll hand over to colleagues now. So the first one up, Alicia, Hereford and Worcestershire.
I'm not sure whether to go to this one or this one. I'll try this one. Hopefully it'll work. Okay. So I'm just going to give you a little bit of background first of all, if I can make this thing work. There we go. So who are we? So I'm Alicia Dunsby. I'm Associate Director of Digital and Technology at the ICS in Hereford and Worcestershire. Quite a small ICS. We've got 2 counties, but they're really large geographically. So our geography is 2.5 times bigger than Greater London, but we've got 10% of the population. So we've got quite a small distributed population across those 2 large geographies. But we're quite succinct. So if you can't do it in Hereford and Worcestershire, I don't think you can do it anywhere because we've got 2 main unitary councils, we've got 2 acutes, 1 mental health trust across both counties and 2 community providers and only 79 practices. So we're quite succinct and quite small, but we've got some challenges around older adult population, which is growing and bigger than most of the rest of the country, and also our rurality and also cross-border issues, as we serve about 15% of Wye Valley's population actually comes across from Powys. So that's kind of us and who we are. I've got a couple of slides kind of about the journey and what we've done. So this is just a graphic we use to share with people about where we've got to and the different systems we integrate. But I've tried to put it really into this table to talk about where we've got to. And I've focused quite heavily here on kind of what we've got to with MVS1 and MVS2, which is the national minimum standard or national minimum viable service that NHS England wants us to achieve. Actually, with our shared care record that we have now, we've actually achieved all of 1, and we're really far forward with MVS2, which is really, really pleasing. But actually, that just tells you part of the story. The next part really is about our roadmap and our challenges. We've been working for nearly 2 years trying to connect our community services and our 111 and out-of-hours services. And that's been a really, really challenging journey. I started with the programme about 9 months ago and was very gung-ho, let's get our priority 1 services integrated, of which those 2 were those. And actually, that's becoming an increasing problem. And so I think one of our problems with our MVS2 and our challenges moving forward is how to get our service providers, not just into systems, but the third-party suppliers, to work better together to help us integrate that data. Because actually, that's a really big mountain to climb. So that's our current challenges in terms of where our roadmap are, but our key challenges are also digital social care, and we talked about NRL earlier. So how are we doing? I think one of our big things this year in the last 9 months since I started with the programme has been to increase uptake. When I started, it was really, really small. We'd gradually added data sets as we'd gone along, and actually a lot of clinical staff didn't really understand what we had and what they could access. And we've really focused on that in the last 12 months. So we've got a more than 50% increase in uptake over the 12 months. And what that's translated into is not just increased access to the number of records. So the top graph is the unique records. I think my graphics haven't quite come through on the slide. So the top graph is the unique number of records accessed per month, and the bottom one is the number of users. And the scale is a bit tricky to kind of show the increase. But where we started last January, February is for each user, they'd be accessing about 7 records per month. What we've got now is more than double the users, and each of those users are accessing each record 17 times a month and rising. So I think we've got a good story to tell there in terms of uptake. But when we look at it across our whole community of staff, we've got about 17,500 staff across the ICS. That only equates to about 20% of our total staff. What we're now going to start looking at is how that equates to our clinical workforce and how we see that increasing usage across our clinical workforce. But it's a good news story and something to build on very much so into the future. So next I wanted to just sort of concentrate on the key points of difference and things that we've developed individually with Hereford and Worcester and what's been important to us. So the biggest things that we've really focused on was care planning. So when we started and embarked on this journey, we'd already identified that care planning across organisations and providers was really, really challenging. So people didn't really understand what a care plan was, apart from what they did within their own individual provider. But equally, we didn't have any way, technically, of sharing care plans or inputting into care plans across providers. And a lot of our care plans do need that input across the different provider landscape. So actually, when we went in with Birmingham and Solihull and Covent Warwick into InterSystems, we were quite excited because there was a module called Care Community, which would allow different clinicians from different settings to input into a single care record. So from the get-go, when we started this programme, we decided that we wanted to focus on that. We then engaged with a number of clinicians and key stakeholder groups around priorities for care plans, and the thing that came to the top, first of all, was end-of-life care planning. And why was that? Well, we identified that actually often there wasn't knowledge of what patients' wishes, and there wasn't knowledge across providers around different plans and how we could use the things like respect to respect patients' wishes at really difficult times. So we set out to deliver a couple of things. So it's multi kind of functional. We set out to deliver an end-of-life tab within our shared care record, which would show the EPACS data, which is the end-of-life care planning data that everybody would need when somebody's in that kind of pathway. The reason for this is actually because we had real differentials across our counties about how that was managed. One county we've got black pair and another we haven't. We also set out to create a digital version of the respect form, which is the recommended summary process for emergency care and treatment form. Lots of people would know it as a purple form that end-of-life patients and people with critical care needs would fill out with their clinicians. And the third one was actually to try and support patients to complete their own advanced statement, which was more about their own care needs, which actually I think the first speaker, Sam, really eloquently outlined how important it is for us to understand actual user needs and what's important to them, particularly when they're in a very critical kind of life-threatening situation. Things that might feel really silly to you but really important to an individual, like how to look after their pets and who to inform when they're in care. So that's what we set out to do, and 2 years on, we've got an end-of-life care plan or end-of-life data set tab within our shared care record that all clinicians can see, and it's proven to be really, really popular and really, really important. We've got a great case study from our hospice that outlines how actually having that information at their fingertips allows them to really focus on the patient and not repeatedly ask the same medical questions to the patient time and time again. But we still haven't got digital respect, and we still haven't got an advanced statement. We're really close to both of those things, but it's been a really long journey to get there. So I wanted to just kind of touch on some of the key challenges within that. So I think what we did at the get-go is we tried to digitise a form and not really the process. We didn't really understand or properly map out the whole user journey and all the touch points between systems and services. We thought we were doing user-centred design because we asked lots of people how they worked and how they did things, but we tried to almost replicate existing processes and we didn't really design the service itself. And that meant that when we gave specifications to InterSystems and had those conversations, we ended up with a product that doesn't really work. So we've had to rework that project a number of times with different stakeholders. Fundamental things like we didn't understand our community nurses couldn't access the shared care record because they use EMIS Community on EMIS Mobile on a tablet. So we've had to constantly revisit the user journey and then revisit the technical design. So we've learnt masses of lessons in the last couple of years because we weren't very mature in how we did this, and we've kind of learnt as we've gone. And I think actually one of the things I've certainly learned is that user journey and really, really mapping that out in detail from the get-go can't be more important. That will then help us to actually work with InterSystems in a fundamentally different way, expressing the user needs but allowing them to prototype and deliver in a different way. Again, we've kind of gone for big bang. We've given a high level requirement and then got a delivered product at the end, and I think we need to move more into a prototyping way of doing things. We've also learned about things like advanced statement, about where to put it. Our original plan was to use Care Community and sit with the patient and take the advanced statement. And actually we realised it needs to be more patient-driven. So our plan now is actually to create a two-way integration between InterSystems and our patient portal. So our original design was all about single kind of pull into a shared care record. I'm now talking about that push and pull between different records to transact different data. So our way forward with that now is to actually create that advanced statement that's patient-led in the patient portal, but bring that information into InterSystems so that our clinicians can see it and share it. So there's some of the key lessons that we've learnt. I think that's also then helped us to move forward with what we're doing now with a two-way API between our patient portal and InterSystems for our appointments. So that is effectively informing our Wayfinder journey to the NHS app and allowing patients to see their appointments. So again, rather than interfacing with several different PAS systems, we've agreed a two-way interface between the two systems. That API, again, we kind of did in a much more detailed fashion with InterSystems, and the result is a much clearer, defined and good product that we've now tested and are ready to go live with. So I think we've learned some real key lessons, and we're moving forward at pace. Our next steps and focus will be further care plans and further integrations between the care portal, our patient portal, and our care community module. We talked earlier about what's important to an individual, so the About Me section, we have that within our patient portal, and we can actually bring that information into our shared care record, and that is on our roadmap. So next steps for us really is a real need to focus more on user-centred design and service design fundamentally, and work differently with InterSystems on getting to the right product at the right time. We've got a really significant capability here, and I think we've only just touched the top of the iceberg with what we do with it. I think it's got amazing potential. I think we're limited by funding because we haven't got any, but also a little bit by imagination. So I think we've got a great fundamental kind of baseline to work from, and I think we've got a really positive future for helping our patients and our clinicians work differently and support their care. Thank you.
Hi there. My name's Diane Bainham. I'm the Director of Digital Care Pathways for Coventry and Warwick. I'm really lucky that I work alongside other ICBs, and everything that is being developed as three ICBs coming together with one system. Effectively, everything that is developed, so Carl's developments and Alicia's developments, I get the benefit of, which is absolutely spectacular, just working collaboratively across the different ICBs. Like Alicia and like Carl, Coventry and Warwick is also very well established with regards to all partners being connected. We're actively sharing the information that is sort of driven across all of the ICBs. We've got all of our partners actually working to the standards. We're really working hard towards the MVS2 and effectively the national requirements. That list isn't all it is. And I think I would be quite pushy to say, actually, nor is it a limit of what it could be. And when thinking through what's next for Coventry and Warwick, what I've tried to do is actually start to change track in the way we're building. Because when we think about what's next, it's critical that we do consider the needs of our users and the reason that we're actually doing this. Why are we trying to ensure this access to information? And I think our keynote this morning was really quite poignant around this point. Care pathways, more often than not, transcend all of our different care organisations. They're going across care settings and they're going across our organisational boundaries. For example, in this particular care pathway, it's the cancer pathway, it's the national cancer pathway. A patient may enter the pathway in multiple ways, from primary care referral through to abnormal screening results, and equally they might exit the pathway in a number of ways with third sector support or community support, meaning no part of the system actually has the full record at any point. That's why we're doing this. And national technology services, our screening services, primary, community and acute care settings are all involved in delivering this particular care pathway. But our clinical teams can only see their bit of the information because of our organisational and technology boundaries. So it is critical to understand the benefit and track the benefit that we're actually delivering, linking through to the patient care that we're actually delivering and contributing to. So one of the main things to consider is actually what is really needed. So above and beyond what we know is in the pipeline, the things that are so obvious to actually deliver that we just get on and do it. So it's easy, well, it's easy-ish, just to connect systems, right? That's famous last words, easy-ish to connect systems. But actually trying to understand what information is actually going to make a difference to the clinical care and make a difference to clinicians in delivering their care, that's what we really need to get underneath of. So it's actually, how do you really launch shared care records into something that is absolutely, without doubts, critical for patient care? Understanding if that information will actually make a difference to care as well, so it's consumable in the environment that is being viewed. That's what I really want us to get to understand in our system. We have to build what is needed and what is important for our users and our clinical teams. And it's important to undertake that research to be able to understand that real user needs and understand real user challenges. We can't seek to properly understand the issues until we've addressed and talked to our users. As digital leaders, we cannot actually deploy technology that really addresses the problems unless we do. So to be able to understand and realise the benefit of the technology that we have built, we have to understand our utility. So for Coventry and Warwick, we've also seen a massive increase in access to shared care records. It's brilliant to see such traction and uptake and adoption. Between December and March alone, we've seen an increase in views of over 10,000. We're now sitting at over 32,000 views a month, which is phenomenal. What about those who are not using it? How do we spread the word? How do we show them the benefit? How do we actually bring people along? My message is pretty simple. We should be designing with and not for. And actually in Coventry and Warwick, we're embarking on a programme where we're actually undertaking that research to be able to go out and talk to people, sit with people, do the research and actually understand what users actually really need. Users embedded in design have much better chance of actually delivering something that addresses their real need. So effectively, for me, clinical input is more than just having a clinical view into what we're doing. It's actually clinically driven design that's important. And we need to stop digital and technology being kind of evolved around digital and technologists and making sure it's serving clinical purpose and actually contributing to patient care. For me, I'll leave you with this quote. It's been adapted from the Imperial College London, which is the Digital Academy. So user-centered design, which Alicia actually introduced, at the heart of digital design and digital care. If we build it together, they will come, because it's what it was needed and actually what they required. Thank you.
So Beasel, I've got a pretty slide as well. This is our, we're at Base Camp 1. They're our organisations. We've got other services on there as well. We've got the prisons on there, maternity services, etc. That's what it looks like collectively between the three ICSs. And I think what's clear to everybody is that we're stronger together and we're better together because we've all only got a limited resource. So the work that Alicia's doing, we're building on. The work that Diane's doing, we're building on. And the work that I'm doing, they're building on. So there is a real benefit of having three ICSs on one shared care record platform. So I was talking to colleagues in NHS England and they asked me to put these set of slides on. So obviously, Diane, we're going to reference what Diane's just said. If you build it, they will come. Well, I can tell you now, Kevin Costner lied because we built it and they didn't come. So we're collectively, we get about 300,000 hits a month on the shared care record, which is reasonable, but it's not great. But what we've seen in BSOL, we did the comms campaign first. We're now at about 150 to 160,000 hits a month. The target annually for this end of this year is to get to 1 million hits a month. And just thought, like, "Christ, is that even achievable?" It turns out it is. It is because we're building more interfaces, so we're getting more organisations on. It is because we already recognise that not all our clinicians are using it in any particular given care setting. So we've done quite a big piece of analysis, and we can tell within the care settings, specifically within Birmingham, even with the acute, we've got some areas within the acute just aren't logging on. They've got the ability, it's available, but it's just not been embedded in their sort of structure, their process, their way of working. So we're collectively working with that. We created a comms campaign, we've shared it amongst ourselves, and we've started to share it wider. So there was a Connecting Care Records conversation a few weeks back. I presented the presentation, and I've shared it since. And if you want a copy, just drop me a line. I'm happy to share this, because we've all probably got the same issue, or we could all probably do better across sort of the UK. One of the things we got our sponsor, sort of a supplier to do, InterSystems, is work with us on this. Because it's their benefit, there's a benefit for them as well. So what they did, they paid for this, they fronted it all up, they didn't charge us at all. They got a professional video company in to help us with our clinicians, with our social care workers, with our other end users, to create a whole host of videos. And we put them on all our websites, and we've started marketing them, and we can already see we've got a greater uptake in those organisations where the chief exec is doing a bulletin a week or a video a week. They're 2-minute shorts. We did 8. They're just general, the benefits of the shared care record, etc., etc. The last one is interesting, and I should have put it on play. I have got one of the videos. It's a 2-minute short. I'll play it to give you a flavour of what we're doing. But the last one was interesting. A group of clinicians had a conversation with us and said, "We heard the funding is an issue." Yet it is. There's no two ways about it. We've run out of national funding. We've used funding for just about every sort of stream that we can get. And it's an issue, and we're going back to the providers now, and we're saying, look, we all need to contribute, which we've agreed in some of the patches, but we're still to work out in other patches. And they said, well, we're really concerned, because there's a rumour, because there was a survey done that said, if you don't get funding, can you continue? And some people answered, we don't know. And that's the truth of it. So they asked for a specific video about, you can't take this away from us. And that's quite powerful. And that's the one video I've taken to the CFOs and said, it's your choice. You take this away. There's 10 of you. There's 30,000 clinicians in our patch. Good luck. So I'd encourage that. So this is one of the videos. I'll just play it quickly. It's only 2-minute shorts, but it gives you a flavour of what we've tried to do.
With the shared care record, at our fingertips, we can see an up-to-date medicines list. We can see their allergies listed. So it means that we can provide much safer care.
Just seeing the detail and granularity of what's happening with patients, not just in my sphere in general practice, but also what's happening in hospitals that I wouldn't have seen before. So it has made a huge difference.
I think it'd be difficult to imagine any of us really doing our work without shared care records now. And simply because it's opened our eyes collectively to the breadth of stuff that's going on.
I've now got access to inpatient documents, so the handwritten ones. So while we're waiting for important letters, I can see what they've written. I understand a bit more what's done in an outpatient setting.
So there are many advantages to having the shared care record platform. Ultimately, it's about delivering better outcomes for the citizens we support in Birmingham, but also it's really good to be able to work together with health professionals.
Once you've had your eyes opened and you've been able, and you can see the breadth of it, and knowing it's not there would now feel like a real impediment to care.
The advantages of the shared care record are really clear. It improves patient safety, it improves clinician efficiency, and the more people that join in and the more data that's in there, the better.
When more information is available to those clinicians automatically, then it does make it easier and a better experience for patients.
It makes sense, and it should just be the way we're working if we're trying to be more digitally inclusive.
From a clinician's point of view, the big advantage is having that information straight away. I can look that up while I'm talking to the patient, and all this helps to speed up the quality of care.
I would be encouraging anybody that has access to the shared care record, because within that shared care record is a huge goldmine of data that can really help inform your care and management of a patient.
So hopefully you all agree that that's pretty powerful. It's pretty powerful when played back to the chief execs, the CFOs, etc. Because these are health and care professionals telling them why they need the shared care record. Like I said, InterSystems provision that for us. So what you need to do is go to your suppliers and say, hey, they're doing it for them, why can't you do it for us? Good luck. So that's all our base camp stuff, but what else are we doing? So these are the sort of the interesting things that we're doing now on the sort of shared care record. So we've got a medicines management tab. So great, we've got the GP meds, we've had that for a while, we've got GP connected across the patch. So we've started now to go back to organisations and re-look at the data they're provisioning to us. And one of the things we wanted is the meds. So we want all the meds for each patient in one simple tab from each source. So we're working on that, and the Mental Health Trust in BSOL and you at University Hospitals Birmingham in BSOL, they did it. So in BSOL, we've now got primary care, secondary care, coming together. So we've got all their medications there. And we'll roll that out across the other two ICSs. So we'll work with their acutes, with their pharmacy sections, etc., to try and get that data together. We've all got to do this. It's in the sort of the phase 2 of the MVS work. Pharmacists, optometrists, dentists. Pharmacists, we're probably doing what others have done in the sort of the regions. We're having a conversation with pharma outcomes. Pharma outcomes are across our patch, so we wanted a single source. We don't want to build multiple endpoints if we don't have to. They appear to be in every one of our pharmacies, so we're working with EMIS and pharma outcomes. We're getting there. It's slow. It's a big ask, I think, of the pharma outcomes team, but they're getting there. And the intent is that we should be live in June, July this year. Dentist. Now, this was hard, but one of the trusts I look after has got hospital dentistry. And we had a few contacts there, and we eventually found a system that's in every one of our community dentists. This was breakthrough for us. So Rego are that organisation. So if you've got them in your patch, which they appear to be just about everywhere, they are, it's not so much an EPR, but it just happens to be a system that's in every dental practice. And you can do in-context launch through the patient registration, which is key for us because we don't want to manage account management, etc. So everything we do is in-context launch through sort of patient registration. So Rego seems to have cracked the nut. We're working with them. We'll be the first to type. But again, I've spoken to them. They're happy for me to share all their details. They're really interested and they're really keen. And they're happy to carry the costs on their side of the can completely. So I think they're worth looking at. James alluded to this. We've had WMAS for a while. In fact, I was hoping Phil was going to be here today from WMAS. So we connected WMAS to our shared care record a while back. And they've been great. And we're lucky that one ambulance service provisions across all 3 of our ICSs. Sort of on the back of that and conversations with some of our acutes about what's missing, West Midlands Air Ambulance came up into the conversation, and we've just started the technical conversations with them. They deliver to all our hospitals. So we want to get them on board so that we spoke to them. Technically, they feel they can do it. They meet the IG requirements. So this is another foray. The IG requirement was pretty easy, actually, because the way we wrote the ambulance service element, it covers it. So thank God I haven't got to go through that again. So, right. So in our, I don't know whether you're going to get this reference. So in sort of our ICS currently, we've got one of the prisons. That's Prison Break, by the way. Probably not the best picture. One of the prisons is serviced by one of our providers. It's the Mental Health Trust. We provision sort of healthcare services in one of the prisons. So that was pretty easy for us to link up. So we've actually linked prisons in BSOL. We were quite fortunate. But we wanted more in this region, in this area. So they're all on the MOJ system. They're all on System 1. It's pretty easy to do. So we're looking with one of the providers of prison services there to see if we can get all the prisons on in this region, which it's just a missing facet to the clinical record. James alluded to care homes. So we've got, I'm sure, like yourselves, we've got hundreds of care homes. and they're all using disparate pieces of software. We've got a few big hitters though, and two of the software providers are on the screen now. So Nourish and patient-centered software provision a fair proportion, they're an APR system provision to a fair proportion of our care homes, and they're looking to onboard onto the NRL. And what we're doing now in the region is going back to those other care home providers and their software providers accordingly and saying, look, NRL might be the answer. These two are doing it. There's a lesson learned and there's a fast follower route here. You may want to look at it. So I know that in the phase 2 of the MVS work, we're looking at getting care homes on. I think that the target is something like 25% over the next 4 years. But if these two providers get on quickly on the NRL, we should have 25% within this calendar year. So that's something else we're looking with, and we're working with the care home providers, we're working with the NRL team to get this done. All right, so there's 4 of us in this sort of partnership, InterSystems. So I've got to be honest. I'll introduce Charles now, but they've always been a partner to us. I don't want to sound corny. They're not giving me a discount for this, and that's for sure. But they have been part of our journey. They have worked through it. They have put the hours in, just like we've put the hours in. I've probably paid for those hours, but they've put the hours in. I mentioned COVID. They went £1 million into the wrong colour for us. They went £1 million red for us. At risk, and I really do see them as a partner. So this is some of the interesting work that we're getting InterSystems to do with us. They're working with us on this, and I'll introduce Charles now. Thank you, Charles.
Morning. I'm very conscious that the lights down there are really, really bright, so if the reflection of my head is blinding any of you, please let me know. My name's Charles King. I've been with InterSystems about 13 years, primarily working in EPR and shared record. I'd been asked in the last 6 months to pick up BSOL as a key account for InterSystems. Really enjoying it. Really enjoying it. As you can hear, I'm not a local. I'm sitting there reflecting on what the other presenters were talking about and thinking, oh, wow, I really wish I'd seen these presentations before I had to come up here and talk. But it absolutely fitted in. That's why I thought it was good. I'm not going to stand here and do what you would normally expect from a sales guy and do it about features and benefits. I'm not interested in talking about that. That's not how I work. What I really want to talk about is what we're going to be focusing on working on with these guys. And if I was to summarise it, it's really just about 2 things. It's about adoption. They've spoken about projects that are really important to them. We need to continue that. I'm a great believer in uniformity. So Dan was talking about one person builds it, everybody else gets the benefit from it. Massive believer in that. Value is the other one. Now, you might not find that very surprising, given that I'm a Scotsman. I'm always playing to the cliches, but I'm a massive believer in value. And value for me is about relevance. People will use something, so that the Kevin Costner quote earlier on, I think it's half right. But it's got to give you value. Is it relevant to me? It may be a fantastic piece of technology, it may be a fantastic piece of functionality, but is it relevant to me? Does it make my job easier? Is it, frankly, saving me time, money? Is it making my job safer? That's what people are interested in. So really that's what I'm wanting to talk about today, and maybe give you some examples of what I think we should be working on. So, no big technology talk today. I think there's a general realization that technology is there, and it's how we start using that technology to the benefit of everybody. That's what we really need to start focusing on. These guys were talking about how their own organizations are working differently and how they're setting specifications and looking at requirements and working with the users, and that's incredibly important because the technology should support that. I'm a massive believer in that. Okay, so I'm going to focus on 3 areas today. I'm going to talk about an ecosystem approach that I'm a massive believer in. I'm going to talk about cost of care, sorry, playing to the cliche, and then I'm going to look at how do we drive some greater efficiencies as well. Okay. So I do not believe, oh, here we go, here's a wee bit of heresy for you. I do not believe that any supplier can do everything for everybody. In our systems, for a long time, there was probably a mentality of absolutely. I do not believe that. I do not believe that. I've seen that in my whole working career, that you get greater benefits from working in partnership, often with your competition. Oof. Please don't record. Oh, I know it's been recorded. I'm in trouble now. Often with working with your competition, and we've seen that in so many occasions. So I work in Scotland, I work in Ireland, I work down here, and I massively believe that we all have to work together. There are pieces of functionality, technology that we will never do, that we as an organisation will never be able to supply, but we should be working with your other suppliers in order to be able to provide you with the best solution, the most economic, the most cost-effective, the most safe solution that we can do. So what we need to do is to take the learning that we see in other areas and we bring it to you. Because often it's really difficult for you to see good practice in other areas, and that's something that we need to start doing. So some of the areas that we've been looking at are, how does your shared care record, your patient portal, how does that support your mailing strategy and reduction of costs, your patient engagement strategy? So how does your shared care record, how does your EPR actually support all of that whole journey? We're doing some really innovative work with with partners just now. InterSystems is a platform essentially, and so we've got thousands of partners worldwide. We're constantly looking at new and innovative partners, and I think there's a role within InterSystems to bring that to you as our customers as well. And we're doing that through a set of conferences and innovation workshops that we run as well. So really keen to try and bring some of that and work with the people that you think we should be doing. And even if that is, difficult conversations that we have to have. And I'll give an example of that later on. The cost of care. So, here's a biggie. So on one hand, we've recognised that the most effective and the cheapest cost of care that we can provide is by keeping somebody in their own home. And on the other end, you've got your high dependency ICU unit in a major hospital is the most expensive form of care. And in between there's a lessening of cost. And frankly, what we need to be looking at is how do we support more this end rather than this end? And we have a number of projects that we've been looking at in this. And I think this is a how do you eat the elephant type thing. We need to start with a few bites. And so we've been looking at three kind of main areas in how we're helping our customers and how we're going to hopefully help the guys in supporting in this. A really important project that we've been working on is the MyPath Cancer Care project. This is an amalgamation of 7 different countries, 8 academic and health institutions looking at how we support long-term conditions. So working with multiple EPR vendors, working with multiple portal suppliers, working with ourselves and the academic institutions, looking at how we can come up with a model that supports, specifically in this case, cancer care, and how you have your patient involved from the minute that they're diagnosed and how they stay involved all the way through how their care team are constantly updated through a set of communications, questionnaires, involvement, how they can question, how they can interact with their care team, how their care team are managing it when even nothing is happening, where you want to know that there's been no changes. That's what actually pretty important to them. But then in that horrible situations when something bad has happened or there's significant changes or a deterioration over time, how is that your care team alerted as part of that? And that's a really exciting project. We've built a model there that we think that we want to start deploying, specifically with these guys. I've spoken to Carl and the team about getting them involved in this project. There's a lot of learning there from us. I don't think that we as a supplier are particularly close to the innovation in these types of areas. So that's been really important for us to be involved in that. And again, a really good example of learning somewhere and then looking to share it in multiple places. And that's what we're really keen to do. We've spoken about the care planning piece and facilitating the discharges and making that simple and easy, and we're seeing that as some of the guys have touched on, or Carl I think is talking about later about the One Coventry project, and that I think is about that kind of uniformity. How do we take that elements of the products that we've already deployed and then start deploying them back across the other ICBs that are part of this consortium as well? So I think really good practice needs to be encouraged as part of us. And again, that's about InterSystems playing a part in the adoption. I do not believe, as evidenced by the videos that Carl was talking about, I do not believe that adoption sits with the customer. I think it's a shared responsibility. So that's something that we're looking to work with the ICBs on as well. How do we encourage that adoption? And again, I think that's back to relevance as well. And finally, we're really looking at how do we avoid readmission, because this is a costly kind of model that we have here. And I'm going to give a small example of what we're doing in that space. When I first started working with this group, I was amazed, frankly, at the level of data, the industry that they've created about building this data and then leveraging value and creating this incredibly rich and mature shared care record. Massively impressed. We have been working on this in Scotland for the last 10 years and nowhere near as rich as this, nowhere near as accomplished. I hope to get Scotland there at one point, but well behind the curve in comparison. But it really struck me that, okay, we've got all of this data. Now what we need to start doing is leveraging the real value from that data. So one of the things that I'm keen to look at is how do we take technology, functionality that we've developed for a different purpose and start deploying it to support this. So InterSystems, as I said, is based on a standard platform. That's as technical as I'm going to get, which means that stuff that we've built maybe in our EPR world means that we can actually deploy it in our shared care record world because it's all about the data. And in this area, we've been working for the past 18 months on a set of machine learning models, AI models that we've created. And we've created them by looking at specific use cases that we think are of value or have been identified by customers as specific pain points. And that's a really important thing. That's one of the things I really, really want to focus on, because I'm just starting to get into and understand where the pain points, the blockages within the system actually sit with these guys. And that's what we really need to be working on. So it's that value, it's that relevance, it's that focus, and those are the areas that I want to be working on. So we have developed quite a few of these models now. And whether it's from a clinical, administrative, whether it's a revenue management, if it's in the private sector, and some of the more generative AI pieces that we've been working on as well, all of these are now ready to be deployed within our ShCR platform, because it's a common platform. It's about the data and how we use the data. And some examples of these that we have live at the moment. It's looking at emergency times and the predictions. This is one that we've been working on in Scotland, looking at can we divert an ambulance instead of going to this hospital, we're going to send you there instead, based on the current real-time waiting time information that's coming through the system. We've been looking at sample rejection rates and reduction rates, and looking at the cost of running tests and how we can reduce that as well. So it's even, duplicate tests across multiple areas. When you're referring patients, can you take the tests with you, etc. We've been looking at surgery duration, looking at the amount of time a specific clinician is taking in an operating theatre, or based on the type of operation that they're doing, and then providing more accurate information on how long that's likely to take to allow for resource planning. This one doesn't really excite me, I'm going to be honest about that, but this is about, so one of our organisations in the Middle East really struggle with the allocation of staff based on the amount of activity that they have planned. So again, we've been looking at a model that allows us to be able to help with that, the allocation of staff and the resource planning. Clinic no-show. This is a really, really good one for me. I like this one because it's about the numbers. We had a customer who's getting an 18% no-show for appointments. We've reduced that by 7%. Based on their numbers, you know, £150 for a no-show, just for an appointment, rather than for a theatre appointment, it really starts to add up. So again, we can really start to show where the benefits in terms of the cost reductions are in these. We're also, in this one, what we've did is we looked at the likelihood, by creating a cohort based on historical information, creating a cohort of people who are not likely to turn up for their appointments, and then worked with an appointment setting organisation. So you probably all work with them, with people phoning up to make sure people are going to turn. So we looked at the top 20% that were most likely not to turn up, and we only targeted them. And as I said, we got a 7% reduction in that. So by focusing on that and working with other suppliers, really worked well in that space. Readmission rate reduction. So we've been working again, this is one, I think this one was from France, where we've been working on, we targeted looking at the cohort and looking at the historical information of people that are likely to be readmitted based on a number of criteria. And we targeted a 4% reduction, and we actually achieved an 8% reduction. And again, this is a really simple one where they could actually look and say, it's going to save us €6,200 per every single time we avoid a readmission. And this is by changing the drugs, changing the care, keeping them in hospital. It's changing, it's that kind of early intervention on the cohort is what we're looking at here. But again, it's based on the information that's already there. So that's really what we're kind of talking about. And diabetes, the Western world's biggest problem, or one of the biggest problems at the moment. Again, early identification before symptoms are starting to be, or before you start treatment. It's that kind of 3-5 years before before people start needing treatment. So early intervention and care and working with the community, working with the GPs in order to be able to avoid having that more expensive care in the long term. So just to kind of wrap up, really interested in working in partnership for the success of the customer. Really interested that we start leveraging the platform. InterSystems is a lot of technology that we really need to educate everybody about to put it in a better place. Increasing the adoption and the usage through making it as relevant as possible. And frankly, let's keep looking at where the pain points are and how we can use the technology to leverage that. So that's all I wanted to say. Thanks very much.
Thanks, Charles. So I should probably say that InterSystems, they came to us as their customers, as well as the rest of their customer base in the UK, and they set up a ShCR user group for their customers, and we meet, and some of this information shared with us, and then we also put requests into them. So as a user group, it's not just that I pay once and Alicia and Diane benefit, but as a user community, we pay once and all their customers benefit. And I think there's got to be done more in that sort of supplier world for those sort of things generally. But they're very good at it. And all the sort of the items that Charles went through, we've gone through together to say which ones are plug and play and which one would apply to us and our region. Because this is how we move to the base camp 2, if you like. We've all built it. We're data rich. There's no two ways about that now. And it's how we use that data and move it on. One of the other builds we've got is virtual wards. We've put virtual wards. We've put it into the. We use Dockerbo. Other suppliers are available. We've managed to get it into the shared care record, and this has changed things for us. So this is also the next steps of where we're going, how we're getting to base camp 2. Charles alluded to it. In our region, we've got integrated community teams. I'm sure you've got them too. And the integrated community team is about MDTs. not just those who are directly connected to their shared care records through their EPRs, but others. So the tertiary organisations, the care worker, it might be the unpaid worker, but other organisations, other people that want to add to the care plan. So we've got the data, it's in the shared care record, and it's now how we leverage it. So in the systems, they've got a platform called Care Community, and we bought that as part of our tender. Now, I don't think we knew what we were buying when we started this, I've got to be honest. We put a tender out, we put a few things out, and they came back with, this is what you'll get for your money. And we bought this Care Community platform, and we've now started using it, and using it in anger, and it's great. And all the data that's in the shared care record is automatically transposed into the community portal, we've now created a case management tool. We talked about care plans, so we now use this case management tool with those integrated teams. It's the same data, but now we can have care plans that everyone can read right into. So it's slightly to the left of the shared care record. It's fully accessible through the shared care record, but it's slightly to the left of it. So we're using that data layer, and creating a case management tool. And on the back of it, we can have risk, we can have care plans, we can have the respect forms, we can have the diabetes we're looking at now. And in fact, I think Vikesh is around. He spoke to me about a number of other conditions that require sort of individual care planning. So sickle cell was one. And we're looking at doing the same thing. And they're low code and they're easy. And they don't need techies to write the care plans. They're really easy. It literally is plug and play, pick that field and drop it in. So our case management teams are using this in Birmingham now. We've got 4 sort of localities, 2 are operational now, the 3rd one goes operational in the next 2 weeks. It's really easy to use, they all love it, and because we're doing this sort of iterative piece at the moment, we've created it, it works, but we're now having regular catch-up with InterSystems, with the sales team and the techs, and saying, look, could we tweak this, can we tweak that? And they're pretty good, they're doing it on the fly, so if there's a field needs moving left and right, they're doing it, no issues. And now we're looking at phase 2, okay, where do we take this next? Now, in Cov and Warwick, they're looking at this on a much greater scale. But they're building it on the back of the work Beasel have done, which is great, because they haven't got to start from new. So that's something we're looking at, something that's being developed. I mean, I put these on to kill time more than anything, but they're flexible. They're flexible templates, they're tasks. It is really easy to use, and you can have the shared care plans. And there's an example, the end-of-life care plan, which Alicia alluded to, and that's in there now. I didn't know where we were going to be on the time frame, that's all. Okay, so what else are we doing? How else do I leverage this data? So NHS login, okay, they're there, they've done that, well done, and they're doing the NHS app, which is great, because at the end of the day, all this data is patients' data. I'm interested, I want to take some of the burden off our acutes as well, which are also being asked to provision the same data. So we're looking at how we can do that in the shared care record, because it's already there. So in the Mental Health Trust, like everybody else, we've got to have a patient portal. So we've built it on the shared care record in our patch. Now maybe this will be taken across the ICS, maybe it won't. It doesn't matter. I think we were doing it partly as a proof of concept, partly because the Mental Health Trust had to have one, and also a first of type. I know others, shared care records, are trying to do it, are interested in doing it and want to do it, but we've not been enabled to some degree because of the Wayfinder program and everything in between. So we've taken it on ourselves and we're doing it. So this is our patient portal within Beasel Mental Health Trust. It's great. It's a modern design. It's modular. It fits on the mobile phones. It's really easy to use. We can import appointments. And we're doing this. We've got it up and running. It's working. Full data access, so the patient can access the data that's applicable to them. And they can also write into that as well. So picking up what our keynote speaker said this morning, Sam, we can share that data, which is great. General management, we can give consent, which is important. We've got a whole cohort of patients who are obviously consent models for others to see and share. So that's built in. Submit care plans, submit your own care plans. We're looking at doing education on it, where we've got trusted sources of information, and we don't use Dr. Google. He's fine, but he causes problems. So if we've got, in James, a psychiatrist at the Royal School of Psychiatry, etc., if they say this is a good reference and a recognised reference, we can put that in there. So to better enable our patients to take care of themselves. So that's it on the sort of the portal perspective, how we leverage, how we're not just leveraging what we've done, we're also, I suppose I'm tying people into the shared care record. And I'm developing a sort of ecosystem of shared care record tools and abilities. And it's about having a single source of truth of data and building off that for me, and not having multiple sources of data to the left and the right. So we're very keen to do the NRL. We're very supportive of what the National Record Locator can do, should be able to do in the future. We've always been sort of on this journey with them. We're very keen, we're very supportive. I'd like to do structured data, if I could, on the NRL, and I think that's where we need to go to. But I think as part of the Connecting Care Records programme, it's a good first step. And I guess maybe we have got to do the lowest common denominator to start with, and just get people on there. And I think it's important, we all say it, the shared care record is great for your region, but patients don't respect regional boundaries. They'll go to their nearest acute or their nearest sort of care sector, and that might not be in your ICS, but they might be registered to your ICS, so it makes things very difficult. So I think the Connected Care Record is a fantastic programme, needs doing, and I think the NRL is a good first step on that, and we're onboarding on that. InterSystems have done the test work. They went to the hackathon. They managed to demonstrate that they could get the patient data flowing across the NRL, and we're doing that now, and we're working through that. And I think it's a great first step. I know other suppliers are doing that as well, but I really do think we've got to do this collectively as a nation. So where else do I sort of draw out some sort of value? So we've got a master patient index by default. We've connected all EPRs in our region. You know, I mean, we've connected maternity services, the prisons, ambulance services, etc. We have got an electronic master patient index. Okay, now let's leverage it, because there are a number of acutes, a number of organisations in our region that are trying to buy master patient indexes. I've got the biggest master patient index in my patch by a long way. And if we can connect others, whether it's the NRL or whether it's using things like GP Connect, etc., we could have an even bigger master patient index collectively. So I'm trying to now leverage how we use the master patient index. So one of the obvious ones for me was to look at the networks that span boundaries. So West Midlands Cancer Network were the first to come to us, and they said, right, we share data, we've got specialties, we've got clinicians who work in Coventry and Warwick, but they come and see patients once a week, once a fortnight in Birmingham, and it's a real pain because they can't see the record. I said, okay, we can share the record, we can share the patient record. And they said, oh, well, Carl, cancer records are not quite the same, and we don't want everything shared on the shared care record. I said, okay, we can pass things through, we can have RBACs. We did a piece of work there. And then we talked about, okay, but it's bigger than our 3 ICSs. Okay, let's see what we can do. And we need a way of tying up these patients across regions into a bigger network. And that's where the Master Patient Index came into its own. So now we can use that Master Patient Index to match patients across the whole of the cancer network. And although we're doing West Midlands at the start, I think I'd be interested in working with other cancer networks to see how the work we've done could be replicated in other regions. We're not going to charge for it, we're going to give it all away because we're all in this together. So the West Image Network is also a rather large network. They're looking at procuring a new system, a new approach, and that's been in flux for a while. But the one thing that hasn't been in flux is, okay, could we use the shared care record? Could we tie into it? Could we use the Master Patient Index to link all our organisations together? Absolutely, of course you could. And we're keen to do that. We can also, though, flow notifications to the shared care record to say, hey, you might want to look, there's an image turned up. Some images we can flow through the shared care record. They're low intensity, there's not much data flowing. It's okay to do it. Others, we may need to use the vendor neutral archive, etc. Another one, West Midlands SDE, secure data environment. So not only are we going to share the Master Patient Index with them, we're also going to use our pipe, because we've built a connection to every trust around our region. So we're looking at using the pipe. That doesn't mean we're going to flow the patient data from the shared care record, but it does mean we've got a connection that we could potentially use. And we're looking at what that means. So we don't have to build more endpoint connections across our region, which I am adamant needs to stop. And finally, the same sort of thing, LIMS, so Laboratory Information Management System. We've got a new procurement going out across the region, and they are absolutely keen to use the master patient index so they can work out where the order was placed, against what patient, in what system, send it to the labs, and we can get the right data back and the right results back to the right organisation. So this is how we're sort of taking us to Basecamp 2. You'll be glad to know that's the end of the presentation. John's given me the 3-minute warning. But that's how we're trying to take us to Basecamp 2. So we've all done the MBS stuff, and it's now how I leverage this huge data lake, as well as combine with other organisations, other systems, other networks to help share that benefit. So that's it from us. Thank you very much.